Hi guys, can you hear me? Is my sound clear? Hello students. I think there is a big lag in the video. Hi all. I hope you can hear me loud and clear. And I think there's a lag. So just send some comments if you can hear me loud and clear so that I know what is the lag between my talking and your responding. I'm going to be answering your ENT NEET recall PG questions, and I hope you guys did quite well because the ENT के questions काफी simple and very commonsensical questions थे. So I don't think you must have had too much trouble, but I'm going to now tell you what I think are the answers. क्योंकि ये जो questions हैं, these questions are from recall, and we don't know how well we have recalled not only the question, the image, the options. So I'm going to answer based on what has been sent to me. If you tell me that the options were different or the image was different, we will modify the answer accordingly. All right, so are we good to start, guys? Can some of you write how your exam went well? Do you think, did you answer all the ENT questions nicely? नमस्ते सर जी, मेडिको फॉरएवर. वाह, इनकी देखो, लुक एट द एक्सपेक्टेशन में मेडिको फॉरएवर. आई एम नॉट गोइंग टू नो स्टॉप बीइंग अ मेडिको. वेरी नाइस. ये होनी चाहिए स्पिरिट. सो आई थिंक योर ENTs वर फाइन. ओके, सो लेट्स गो विद द फर्स्ट क्वेश्चन. लेट्स नॉट वेस्ट टू मच टाइम. ऑलराइट, तो फिर देखते हैं. Okay, what about this question? This is an image based question. I don't know if this image was asked or not. If it wasn't, please tell me whether this image was asked or some other image was asked, but maybe this is a representative image. Which of the below procedure has been done in this patient? So is it percutaneous tracheostomy, classical tracheostomy, partial laryngectomy, or total laryngectomy? What did you guys answer for this one? सर एग्जाम गया, वो राज भी उसके साथ चला गया. Yes, that's when people say how are things going, I said gone away. Okay, what are your options for this? I think the lag is quite long. That's why you might be typing and I'm not getting it, or I'm waiting for your answers. Okay, let me tell you the logic for this. Let's go one by one. The percutaneous tracheostomy or classical tracheostomy or partial laryngectomy, there will be a tracheostomy tube there. Okay, it's not intended to keep it open like this. But to be very honest, if you are going to if you are going to remove the tracheostomy tube in any of these patients, वो stoma ऐसे ही दिखेगा. It's all going to look like this only. Even if it's, and some people are saying partial laryngectomy, ABCDEGF is saying D, and उसमें क्या टिक किया वो भी याद नहीं है मेडिको फॉरएवर को. So the thing here, guys, is that when it is any kind of tracheostomy or a tracheostomy is there, it is meant to be temporary. Only in total laryngectomy, it is meant to be a permanent stoma where the trachea is now opening like this. The larynx has been removed, the whole thing has been reconstructed, and now the oropharynx is only used for swallowing food. So you will do a tracheostomy in partial laryngectomy because half the airway is still there. So in my opinion, the answer should be total laryngectomy over here. Because they are showing a stoma which is quite well healed, and normally in a total tracheostomy patient you should start seeing the tracheal rings. Okay, you'll start seeing some of the other tracheal rings because the trachea is curved and it is then facing forward. For some reason, this representative image, the tracheal ring is not seen. And in partial laryngectomy, the stoma is not usually permanent. The tracheostomy is done till the larynx heals, and then the rest of the larynx still is functional to some extent for airway. Classic tracheostomy, if you remove the stoma, it look like this, but the idea is to close the stoma after tracheostomy. Percutaneous tracheostomy also you will close the stoma. Partial laryngectomy also you will close the stoma once the rest of the larynx heals. So I think the answer for this should be a total laryngectomy. Palak is like, sir. Maybe because I don't know if the image was different in your case, but I don't know partial laryngectomy or total laryngectomy. I don't think the image is going to be very different, but इसमें logic ये है. because you're going to leave the stoma permanently, this looks like a permanent stoma, and permanent stoma is left in total laryngectomy. Okay. Any questions or doubts over here, you can ask. I'll keep clarifying. There's a big lag between what I am saying and when you are commenting. So you might see my response 2-3 minutes later, but we'll keep going on so that there is no empty space. Okay. All right. Okay. Now this 30-year-old male came to the OPD with swelling over the face. Examination, there was proptosis. He gave a history of trauma 15 years ago. And this is the image. Guys, actually, if image nahi hota, it will be less confusing. But this image is there. But this answer can be answered even without the image, because there is a very strong clue that is being given over here. So, JNA to nahi hai. JNA is juvenile nasopharyngeal angiofibroma, and that will be a tumor coming from the nasopharynx all the way in the back. Unlikely to see proptosis with juvenile nasopharyngeal angiofibroma. And pseudotumor of the orbit, you will see an orbital mass, but you're not seeing that. So we know that it is one of these, whether it is a frontal mucocele or a frontal meningioma. So how do you exclude this? Because both frontal mucocele and frontal meningioma can present with proptosis, and it's a common presentation for both. So this image is an MRI image. Okay, we know it's an MRI. So we're looking at soft tissue. You can see brain. You can see the, the mass over here. What did you guys answer for this one? क्या किया तुम लोगों ने answer इसको? Farhan Sheikh is saying C, frontal meningioma. How many of you agree with meningioma? I saw in certain other, recalls and in certain other videos, a lot of people said it was a mucocele. Many people said it's a frontal meningioma. But what do you think it is? See, there's one clue over here in the question that will basically seal the answer, and that is history of trauma 15 years ago. See, when somebody says there's a history of trauma in childhood of 15 years ago, and then there is a frontal mass or a proptosis or an image like this, it is most likely going to be a frontal meningioma. And also here you can see that the meningioma is there is connection to the brain tissue as well from the nose tissue. There's some amount of nose meningocele that is coming over here. It's not a meningocele, it's a meningioma. And I think history of trauma leading to meningioma is a far more commoner possibility. I'm not saying that you will not have history of trauma in mucocele, but even if you look at literature, it is so rare that after a traumatic face injury or head injury to develop a frontal mucocele. That is basically just some case reports, and it is not recognized as a common presentation. But for a meningioma to have a history of trauma is a little more classical or a little more expected. So I think the answer over here should be frontal meningocele, unless the question was told a bit differently, or the image was a bit different, or the options were different. But from what I have, it looks like it is a frontal meningioma. पता नहीं ENT में क्यों है यार? Meningocele होता है ENT में. It has to come down, no? Herniate disease up here only the brain. That's why we are the cancer of the medical field. Har jagah we have our presence. All right. This is as simple, guys. I don't want to spend too much time on this. 5-year-old child swallowing pain. So this tonsillitis, bilateral swelling of the tonsillar fossa. Which nerve is responsible for ear pain? Though it is written ear, but yeah, that is the pain that all of us when we give our medical exams face. That is ear pain. Pura sal dard. And this is ear pain, which is occasional pain sometimes in the ear. We suffer from ear pain, and the referral nerve is these exams. But this guy is suffering from ear pain, which is the nerve, and that is the options also are not even close. It's a tympanic branch of glossopharyngeal nerve. Auricular branch of vagus nerve is Arnold's nerve. Arnold's nerve is basically, the one that causes coughing and lower heart rate and bradycardia. To do this, when bradycardia and coughing happens, when you stimulate the posterior branch of the vagus nerve, the posterior auricular branch. Greater auricular nerve is a sensory supply. Mandibular nerve is somewhere here. It's not close to the ear. But a tympanic branch of glossopharyngeal nerve called as the Jacob Jacobson's nerve. This is the one that basically, transmits the pain. So you must have seen that in the middle ear, when we draw the medial wall, you will see that the promontory के ऊपर ऐसा nerves रहता है. And from that promontory, below there will be one nerve that is going. That is from the tympanic plexus. It's called tympanic plexus, and वहाँ से this Jacobson nerve is going down the floor, and that is basically also supplying the posterior 1/3 of the tongue and the tonsillar fossa. And that is why it's very straightforward anatomical implication question. Jacobson's. Okay, guys, this one, sir, for ENT OPD practice में सबसे ज़्यादा patient किस चीज़ के complaint लेके आते हैं? Okay, guys, so I will answer all the general questions at the end. I'll finish these, but I will answer this question, okay? And I'll answer it at the end. And if you have any other questions that you want to ask, I'll spend 5-10 minutes answering those. And after that, in the comment section, I can answer if you have any doubts, even later on. Guys, for this fourth question, which of the following is not an indication for the instrument shown below? I hope you were not confused in this, because this is a little bit of a common sense question. Airway obstruction, prolonged ventilation, pulmonary toilet, where the lung is doing pishap, and upper airway assessment. Which did you answer for these guys? For this, what you can see over here is basically a tracheostomy tube. Okay, this is looking like this is a cuffed tube. There is this thing to inflate. So this is a tracheostomy tube. CSOM. What is the CSOM coming over here, Sahil? There is no CSOM over here. Which of the following is not an indication? Airway obstruction, prolonged ventilation, pulmonary toilet, or upper airway assessment. This is a tracheostomy tube. Okay. So basically the question is tracheostomy tube. Tracheostomy is not indicated in which condition? We all know that no one in beach mein. Okay. You know that airway obstruction, you will do tracheostomy. That is one of the main indications of tracheostomy tube. Prolonged ventilation also you do tracheostomy, especially after 6 days of ICU ventilation. You want to remove the the endotracheal tube and convert it into a tracheostomy, because you are anticipating long-term ventilation, because you don't want to cause injury to the vocal cords, the arytenoids, the intubation granuloma, and all of that. That will become a stridor later on. But if you do tracheostomy and then you do good cuff monitoring, you can intubate the patient for many weeks, safely with a silicone tube and all of that. Now the question is pulmonary toilet or upper airway assessment. What is pulmonary toilet? So pulmonary toilet is basically any secretions that are coming out from the trachea and the lungs. We clean it, and the reason why we clean it is by coughing out secretions most of the time. That is a common way to do it. Or we pass a suction and we suction out mucosal secretions from the trachea, from the bronchial tree, and all of that. So in some times when patients have neurological problems like stroke and all of that, they have risk for respiratory failure, or they have some myopathy, they are not able to cough and do their own pulmonary toilet, they're not able to clean it, then tracheostomy is something that can be done. And when that tracheostomy is done, then you can do the nursing care and clean out all the secretions. So pulmonary toilet is also an indication. So the only thing which is not an indication is upper airway assessment, because upper airway is basically defined as anything up to the larynx, oropharynx, nasopharynx, nose, oral cavity. This is the upper airway. All right. So the upper airway is nose, nasopharynx, oropharynx, larynx. Anything below is a lower airway assessment, which you can do from a tracheostomy tube, because you can put an ambu bag, you can feel the lungs inflating, you can do secretions, you can assess it, but you cannot do the upper airway assessment. Of course, you can save the upper airway, but you can't assess it because the tube is pointing downward. So I think the indication for tracheostomy is not to assess the upper airway. It is basically to airway obstruction, prolonged ventilation, and pulmonary toilet. Okay, some other questions, guys. You're asking what is my NEET attempt and 10th 12th percentage. मैं end में बताऊंगा RRM, and RRR को तो ऑस्कर मिल गया है, but RRM को पता नहीं क्या होगा. एंड थैंक यू मेडिको फॉर सेइंग आई कैन सर कैन डू एनीथिंग. यार 4 बार तो इसी में रिपीट कर दिया RRM ने, क्वेश्चन भी रिपीटर. तो 4 टाइम्स आज द क्वेश्चन, मैं उसका आंसर एक बार दूंगा एंड में. ओके, आई विल गिव यू द आंसर्स गाइस एट द एंड. एंड नाउ गाइस, identify the structure marked in the below section. Okay, now here I have some confusion, the arrow that is showing over here versus what I heard that the potential question could be. There are 4 options here: eustachian tube, torus tuberous, fossa of Rosen-Miller, and tubal tonsil. Now this arrow, the where it is showing over here, this bulge is called as the torus tuberous, but this space behind it, that is the fossa of Rosen-Miller. Now I don't know whether the arrow was pointed at the fossa of Rosen-Miller or the torus tuberous, but here in this particular image it is marked at the torus tuberous. If the arrow was behind, it is fossa of Rosen-Miller, where I've heard a lot of people saying that the answer was fossa of Rosen-Miller. It cannot be the eustachian tube. This is the eustachian tube, this is where it is, and your tubal tonsils are here below. All right, okay guys, so that I hope you got this clear. And now this one may be a bit confusing. I don't know, what did you answer for this? 7-year-old kid presented to the OPD with history of fever and breathing difficulty, and X-ray shows this. What is this sign called and what is this diagnosis? Is it a foreign body aspirated? Is it epiglottitis? Is it laryngotracheal bronchitis, or is it subglottic stenosis? Okay, here I have a little bit of a so medical, if you're saying, sir, this was a different image, is it? Okay, here no, technically there can be 2 answers for this, but when you read the question, there can be only one answer. So if I were to just look at this image, I can say that it is laryngotracheal bronchitis also, and it is subglottic stenosis also, because the stenosis at the level of the subglottic area. But because there is child who has presented with fever, this is the only inflammatory condition that is involving the trachea. It is a direct answer that it is laryngotracheal bronchitis. And this sign is called as the steeple sign. Steeple sign. In epiglottitis, you will see the thumb sign. You will see the thumb, angutha, it's swollen up. So the side view will look like this. It will be a thumb sign. Foreign body aspiration, you will see the foreign body. And subglottic stenosis, you will see a stenosis at the level of the cricoid cartilage. But this is because of the edema and inflammation and all of that. So this is, laryngotracheal bronchitis because of fever and 7-year-old. In last question, guys. Is this the last question? Yeah. This last question is a little old question. So this is a 25-year-old lady, female, who comes for audiometric examination, and Rinne's with both 256 as well as 512 hertz and were negative, which means there was air conduction not better than bone conduction there, and positive in 10,024. Matlab udhar air conduction is better than bone conduction. And what is the air-bone gap? यार एयरबोन गैप बताना नहीं बताओ, बट एग्जामिनर का एज इसमें बता सकते हैं, बिकॉज ये बहुत ही पुराना सवाल है. सो एवरेज एज ऑफ द एग्जामिनर इज 50 years. But there has been newer studies that have been done on this. I have read some of those studies. 2020, some doctors came up with a study to validate and quantify that when we do Rinne's test, what percentage of hearing loss or what decibels of hearing loss does it indicate. And the simple thing is, if you look at 256, 512 and 1024, they each, if the Rinne's is negative, they amount for 15 decibel loss. That is like the rough formula: 15 decibel, 15 decibel, 15 decibel. So if it is only 256, then the loss will be roughly about 15 decibels. But if it is 512, it can be 30 to 45, and if it is 1024, it can be 45 to 60. So in this case, your answer will be 30 to 45 decibels, because 15 to 20 decibel plus 15 decibel, roughly it will definitely cross 30. So that's why 30 to 45 would be a safer range when 2 tuning fork tests have air conduction to bone conduction difference. All right. So thank you guys. I will now take some time to answer some of the questions that you have asked. And uske baad, if you have any more questions, just put it in the comment section right after this live gets over, and I will answer it there. ठीक है. so what is the first question, sir? ENT OPD practice में सबसे ज़्यादा patient किस चीज़ की complaint लेकर आते हैं? Well, I think the most common complaints that we get are ear pain related. But because I am a nose and sinus surgeon, I get a lot of patients with headache, sinusitis, runny nose, sneezing. So sneezing would be something that in my practice would be the most common symptom. But general practice, ear related problems, ear pain, ear discharge, ear itching, khujli because of otomycosis or dryness or constantly fingering the ear, very very common trivial symptoms. In kids, more tonsil, throat infection, dry cough, but generally ear wins when it comes to common symptoms. Sir, then, okay, what is the next question? Somebody is asked, starting troubles 2 में आप न्यूरोसर्जन थे और इधर ENT बन गए. Sayan bhai, in the season 2, I'm playing another doctor. I'm not playing myself. In season 1, I'm playing myself. In season 2, I'm playing a neurosurgeon. So this is the story of a surgeon. So that's why this story is not, season 2 story is not mine. But I'm also an actor, so I played another doctor story. Okay, RRM Forever saying, sir, your NEET attempt and 10th 12th percentage क्या थे? भाई मैं इतना prehistoric हूँ, मेरे टाइम पे NEET था ही नहीं. There's no NEET exam. During my time, we had state CET levels, which were easier to crack. State level CETs and PG CETs were there, where if you are from a state of residence, your competition is relatively lesser. So it was not a national level. National level exam used to be AIMS All India, like your INICET, which has become now. But otherwise, no NEET in my time, so no attempts given for NEET. 10th and 12th percentage. So my 10th percentage in 1995 or 1996 was I think roughly around 66%, and my 12th percentage around 97 or 98 would have been close to 84%. उस समय काफ़ी था. Now competition बहुत ज़्यादा हो गया है. So what book to read for ENT in 3rd year? Yeah, see, because I think the questions are becoming very clinical. I think more than reading a book, you should spend more time in the clinics because all these are applied questions. But even if you take, your standard DINGRA to know what basic things to cover, I think that should be fine. But you can refer to Scott Brown's textbook of ENT sometime for more clinical and logical explanations to some of the things. Because I think DINGRA is more like notes, yeah. But Scott Brown will just explain a little bit through scientific research and literature why it is what it is. So you don't have to read the whole Scott Brown. It's very big, the book. Three volumes are there. But for some topics, especially anatomy and especially physiology, and certain important clinical conditions, you can read that. All right, and sir, NEET UG aspirant, how to crack NEET? How to crack NEET? Why do you want to crack NEET and get into medicine? But if you want to crack it, I think questions are becoming more clinical. So start observing, being in the hospital, shadow doctors, and then try to understand that. I think for NEET UG also that helps to some extent, more for NEET PG. But for NEET UG, I think past question papers I think is the best way. सर, क्योंकि मुझे लगा कि एग्जाम पैटर्न जनरल ENT क्लिनिक प्रैक्टिस से ज़्यादा इम्पॉर्टेंट टॉपिक पर ही फोकस रखा है, तो अनकॉमन होते हैं क्लिनिकल प्रैक्टिकल में. एक ऐसी ही रिकॉल वीडियो में देखा मैंने. ओके सर, आपने ENT क्यों चूज़ की? ENT मैंने चूज़ नहीं की मेरे भाई, ENT ने मुझे चूज़ किया, क्योंकि जो मिलता है वो लेना चाहिए. एंड उस टाइम इतने % कैसे आ जाते हैं यार, जुगाड़ होती है. Okay, so that is it, guys. I don't see any other questions. Champion is saying steeple sign. That is correct. All right, if you have any other questions, I'm ending the live, but if you put it in the comment section, I am sure to answer that. And if you have any other requests for any other videos or topics, put them in the comment section and I will help you with that. Before that, Medic Dreamer is asking, sir, what is your view? Can student crack FMGE? Yeah, of course you can crack FMGE. I mean, FMGE teaching is the same as any other teaching. I mean, science or science, it won't change. ENT is going to be ENT. Even when you take post-graduation in ENT, it's the same thing, but you just study it in more detail with a lot more, issues that are given to you, like thesis and work and clinical load, but it doesn't, change. सर, ENT से आगे सुपर स्पेशलिटी में क्या बन सकते हैं? पागल बन सकते हैं, इसको कौन करता है यार? ENT के बाद सुपर स्पेशलिटी? हाँ, बट अगर आप करना चाहते हो, you can become a plastic surgeon, head and neck surgeon, neurosurgeon now. and some of those things. सर मेरे मार्क्स नहीं आते, मैं बिलो एवरेज स्टूडेंट हूँ. तो that's all right, perfectly all right. I was also a below average student, but if you are smart in what to study and what to remember, you can get whatever you want. All right, guys. Thank you, and I'll keep interacting with you. Leave your questions in the comment section because I need to run now, and then I will respond to those.